Hello, do you hear me?
Yes, sorry, somebody else was on the other call and I was trying to get out so I could talk to you. I hear you perfectly. Can you hear me?
Yeah, I can hear you.
Can you try sharing your slide just to make sure everything is okay?
Yeah. Mm, mm. Does it work?
Yes. Divide and conquer.
Okay. So I will stop. So
Okay.
should work then.
This is the problem. It's being recorded, right? So
Yeah. Sometimes I hear you cut,
so hold
like
on.
your sound is cut.
I think it's my headphones. Out.
Maybe.
Can you hear me better now?
I think so, yeah.
Okay. There's something wrong with something is up with my headphones at the moment.
Mm.
But you can hear me if I do it without.
Yeah, I can hear you. I think it's better without.
Okay, so I do it without. That's fine. Okay.
Yeah, okay.
Okay, and then
Good.
hopefully Mike will come online and we'll be fine.
Good.
Great.
Good.
By the way, thanks for accepting. It should be nice. I'm really looking forward to this because the two back to back would be very interesting to hear.
Thank you for the invite.
Yeah, absolutely.
Yeah, I think it's it's an interesting moment because finally we got the first patients in the US. So it's a new, how to say,
new horizon.
So yeah, indeed.
Excellent. Great. So
Manjit, I think I will use like 21, 22 minutes. I tried to do it in 20, but I'm not able to manage in 20. So if you don't mind, I will use 2021.
That's fine. Don't worry. It's not like I'm going to cut you off or anything. It's not like that. Don't worry.
Since we have like 20 minutes at the end, I think it's
sure.
We have some margin.
Not to worry. It's perfectly fine. I mean, I'm not timing you, so it's okay. And I'll keep the introduction short, so you'll have more time. Okay. So now you can go and relax.
Okay, good. So hopefully Mike will connect soon.
Yeah. But as I said, I said about 5 minutes before, so we still have 10 minutes, so it's no problem. Should be perfectly okay. But are you in the where are you at the moment, Yolanda?
I'm in Spain, in Santiago.
So you are in Spain. Okay.
Yeah, I'm in Spain now, these days. Just came from Taiwan. Very nice.
Oh, really?
Very nice place.
Nice.
Yeah, it was very nice, indeed. They are building 13 proton therapy centers and a second heavy ion therapy center in that small country. It's unbelievable. It's amazing.
It's incredible, isn't it?
It's incredible.
Where is the money coming from?
I don't know, maybe. I think they have a good industry there, semiconductors and so on, but I don't know if this is paying everything.
I don't know. Okay, let's hope Mike joins soon. I'll just put myself on silent.
Good evening.
Hello, Sandro.
Ciao, Maggi.
Ciao, Sandro.
Ciao, Yolanda.
Ciao.
Thank you for participating to the seminar.
My pleasure.
Looking
Mikkel
forward
is
to
also
it.
connected or not?
Sorry?
Mikkel is already connected or not?
No, not yet.
Okay, very good. Very interesting topic, indeed. Thank you,
Absolutely.
Majid, for organizing it.
So, Sandro, do you want to do the introduction?
No. I'm
Please.
just here to listen.
Oh, come on.
No. You are the boss, and you do the introduction.
Well, we already said to Yolanda, I will keep it very short because then she can have extra minutes for her talk.
Very good. Very good. I think that this is really a very, very interesting topic. We look forward to hear Yolanda and Mikkel on that.
I love the title, Divide and Conquer. I love it. This is very appealing to me.
Yes. How many attendees are expected, Majid?
This morning, 150 were registered, but I haven't looked later, but there were already 150.
Oh, very good.
It's a very popular topic, Yolanda.
Hi, Manjit. Hi, Sandro.
Hello. Hi,
Marco.
Marco.
How you doing?
I'm fine, and you?
Very well, thank you.
You are on holiday, t-shirt.
I'm always on holidays now,
Yes, when
of course. I don't try to wear a tie anymore.
once it is retired, right?
But we have also people that participate to meetings from the boat. I remember Maurizio this summer was sailing and connected.
That was just to make us envious.
Yes.
Yolanda, do you have? I don't have Mike's mobile. I hope everything is fine.
Sending a WhatsApp because it's weird that he's not connected yet.
Yeah, he would be. Could you try to see if?
Yeah, I will send a WhatsApp.
Yeah, please.
Let me. So I just send a WhatsApp. Let's see.
Hello, I'm here.
Hi,
Great. Mike, we were getting a little bit concerned.
No,
We don't hear you, Mike.
how about now? Can you hear me now?
Perfect.
Yeah,
Great,
better.
thanks.
Yeah.
Do you want to try sharing your slides to make sure everything is fine?
Yes, I can do that. How about that?
It's not full screen yet.
Right. Okay, there you go. Good.
Okay, perfect. Great.
All right.
Thanks a lot for accepting. Really looking
Yeah.
forward to this divide and conquer and from lab to clinical implementation. Like it.
Thank you very much.
Thank you for inviting me. I appreciate it.
No, it's our pleasure. We are really looking forward to it. It's such an interesting topic, and I couldn't believe that we were actually getting into clinical translation. I've been listening to Yolanda for a long time, all of this stuff. So now, first patient. Perfect.
Yeah, it's exciting.
So normally, I give a few minutes for people to join. As I was telling Sandro this morning, I looked and there was 150 people registered. So sometimes it takes them a little bit of time to connect. So
Quite popular seminars.
Yeah, well, actually, mostly they are always more than 100 people connected. I mean, registered. Not everybody can connect.
It's a big success.
Yeah. So Mike, also just to say, so we record these and they will appear on YouTube channel for HITRIplus. You know that, right?
I didn't, but that sounds great.
Okay, good. I did write in the message, but just want to double check that we are
Okay.
recording and they will appear.
Yeah, sorry, I'm sure I missed it. So.
No, I just no, but it's really important that you're aware that we are going to be recording this. I don't want you to be taken by surprise.
No problem.
Okay. And HITRIplus has its own YouTube channel, so thanks, Sandro, and his communication team.
Communication team. Sandro is not so advanced.
I said his communication team. No, we just know what we would like, and then they have to make it happen, right?
Yeah, not really, I would say, but they are doing very well. They are doing very well.
Yeah. What do you think we should do? We could already have a little so there's about 45 people joined so far. So give a few more minutes. Sandro, please have a little conversation, perhaps, so that people don't. I mean, I can start, but have you? I have never met Mike, so it's the first time I see him on Zoom. I haven't met Mike in person. So, Mike, perhaps we are going to ask you to say something about yourself.
Sure. Yeah. I know Yolanda, and that's about it so far. I recognize that name. So I again happy to be here, and I know you guys are joining probably much later than us. So, but happy to be here and happy to present with Yolanda. So she'll set it up here, and I'm sure give a great background, and I'll try not to disappoint people when she's done.
You absolutely will not. We're really looking forward to this. Maybe Sandro can say something about HITRIplus since before we start. Sandro, would you like to say something about the project?
Yes, but very briefly, in the sense that this initiative has been approved by the EU in 2021. We are going to we ask an extension, so most probably we will complete our work by spring 2026. There are many goals and purposes in this project, but basically we have three pillars. One is networking, and is coordinated by Manjit. There is another one that is access. That means opening of the carbon ion facilities in Europe to the community of research and clinicians, and this is coordinated by Marco Durante. And then we have a pillar that is devoted to, let's say, new developments, technical improvements, research topics. It's called JRA, and this is coordinated by Maurizio Bretenar. And in the pillar of coordinated by Manjit and networking, we have many topics dealing with communication, with formation, with technology transfer, with clinical, let's say, networking and common language, let's call it. And of course, one of the most, let's say, popular activities in this is linked to these seminars that are organized, I would say, every couple of months so far. And we try, and Manjit is trying to, of course, to cover all the hot topics that are related to ions and similar things. And this time we have this very interesting argument presented by Yolanda and Michael, and so we are really pleased that you are here. And I think that now we are close to 80 people. And so it's time maybe, Manjit, for you to
Okay,
introduce.
I think so. Yes, I think we can start now. So good morning, good evening, good afternoon to everybody. Welcome to our really interesting seminar today. And I think most of you have been hearing from Yolanda and her mini beams. But today we are really going to go from mini beams to first clinical implementation. And so Yolanda will give the first part, and her point, divide and conquer. I really like this mini beam radiation therapy. And then Mike's going to talk about the first clinical implementation of mini beam radiation therapy, why and how. And so let me just very brief introduction. Yolanda, she's a research professor at the Center for Research in Molecular Medicine. I want to say Medicina, but I will say molecular medicine and chronic disease in Spain, and a senior researcher at the Institut of Curie. So Yolanda, please, the floor is yours. Thanks very much for accepting, and we are looking forward to hearing your divide and conquer.
Thank you very much for the introduction and for inviting me to this seminar, to this webinar. Well, it's really a pleasure to be here with you today and to have the opportunity to discuss about mini beam radiation therapy. Most of you who know me, you know that has been one of my research passions during almost 2 decades now. And I think this is a really exciting moment in the field because finally the first patients have been treated very successfully. And I think this opens a new horizon for the field. And I think we will see very interesting results coming. And Michael Grants will present results on first patients. And I will give a very general overview and also historic overview of the technique. I will not go into detail or in depth, but I will try to give you some illustration and so on. The good results we have been getting in terms of preclinical experiments. And I think those results could illustrate why clinical trials are now being considered for mini beam radiation therapy. So for those of you who are not very familiar, mini beam radiation therapy is a type of spatially fractionated radiation therapy. This means that instead of using large beam sizes and trying to deliver homogeneous distributions as in a standard radiotherapy, we are going to irradiate with an array of narrow beams. And those beams are spaced by a certain distance, and this leads to very heterogeneous dose distributions with areas of very high dose called peaks, followed by areas of very low dose called valleys. And this way of irradiating activates distinct biological mechanisms. And what has been observed in numerous patients' treatments in SFRT and also preclinical experiments is that this leads to a remarkable increase in normal tissue tolerances and opens the door for a dose escalation in the tumor. There are several forms. We have grid, lattice, mini beam, microbeam radiation therapy. And the first difference among the techniques is the size going from micrometer size in microbeam to centimeter size in grid. But most likely the difference is slightly more profound than that because not all the biological mechanisms observed in microbeam, for example, are going to be observed in grid, although the techniques share many common features, let's say. So crystal lattice have been already used with patients for many years, mainly for the treatment of bulky tumors in the context of palliative treatment, although there are also some cases of curative intent, but mainly they are used for palliative intent of bulky tumors. And then microbeam radiation therapy is still in preclinical stage. And then we have mini beam radiation therapy that for me is a technique that offers a good compromise between the thick beams used in grid and lattice that are easy to implement, but then somehow you're going to have a limit in terms of the tolerances of the dose tolerances in normal tissues, and probably they are not treated to treat some very radioresistant tumors. And then the string conditions of microbeam radiation therapy. So in mini-beam radiation therapy, we use beams around 0.5 millimeter to 1 millimeter. It's a technique that was proposed by Avram Dilmanian in 2006. He was born in the Brookhaven National Lab, so in a large synchrotron. Avram Dilmanian proposed the technique as a way to overcome the difficulties or the limitations of microbeam radiation therapy. He published a first experiment with very good results in rat brains. I was already working at the European Synchrotron Radiation Facility in Grenoble as freelance scientist when I saw this paper, And I was supposed to work on microbeam radiation therapy, but I was so seduced by the idea of Dilmania and the fact that this technique could be extracted as such synchrotron sources. So it had a lot of more clinical possibilities than microbeam. That, well, it took me a couple of years to convince the SRF management to go in that direction and to move from a little bit to from microbeam to Minibeam and try to expand our possibilities. So it was in 2008 when, with the help of engineer at the SRF, Michel Renier, we implemented Minibeam radiation therapy at the SRF with a technique that was kind of very flexible. We use a wide beam chopper that was very flexible to change beam width and center to center distance. And then the first experiments started at the synchrotron. And already back at the synchrotron, we saw that Minibeam was very efficient in increasing lifespan in glioma-bearing animals. And also, we performed those escalation studies in which we saw that the technique offered good possibilities to increase the peak dose up to 100 grays in one fraction. But still, we were in the synchrotron domain, and I was very much interested in the possibilities of this technique. The major advantage that is that the technique could be expanded, could be implemented outside synchrotron sources that, as you know, there are very few in the world. It's quite limited in terms of future patients' treatments. So one of the first things I did when I moved outside synchrotron was to implement the technique in a small animal irradiator, in particular in a SARP, and we implemented in a way that we could irradiate autotopic models from different angles. And we implemented the technique in 2014, but it took us a while to publish the paper because we were asking for a patent. And then in parallel, there has been some other implementations with some other small animal irradiators, and also most recent, some other clever ideas using variable collimators and some others. All of these were in small animal irradiators, which are excellent tools to gather comprehensive radiobiological data to try to understand better the technique and the biological mechanism. But Minibeam radiation therapy is not limited to small animal irradiators, it's not limited to synchrotrons. It's a technique that is very flexible. You can use it with kilovoltage and voltage X-rays. You could even implement it in megavoltage Linux, although the implementation is a little bit more complicated, more limited because of the lateral scattering of megavoltage beams. And then you can implement it with charged particles, with protons, carbon, ions, etc. And in my opinion, charged particle implementation have some advantages, especially for deep-seated tumors. But nevertheless, it's a technique. What I would like to stress is a technique that is very flexible. You can use many different beam qualities and beam types, and we don't depend on the dose rate. We can work perfectly with conventional dose rates. So what the technique has shown with all the different implementations is that it's able to increase normal tissue tolerances and increase or provide an equivalent of superior tumor control than conventional radiotherapy, even in very aggressive tumor models. So for example, in the small animal irradiators, we observed that we have a net gain in normal tissue tolerances. For example, we can irradiate the whole brain of rats with 20 grays average without significant toxicity, contrary to conventional irradiations. And at this level of dose, we can obtain an increase in glioma, increase of survival in glioma-bearing animals. I like especially this study provided to me by Professor Chang, University of North Carolina, where they used as well small animal irradiator, and they irradiated the full body of mice, either with conventional radiotherapy or with Minibeam. And the animals that received conventional radiotherapy non-grays died by day 8, while the 90% of the animals that receive Minibeam radiation therapy survive to the end of the study, 1 or 2 months, and show practically no tissue damage in none of the organs evaluated. So those are very strong results that shows clearly the advantages of Minibeam radiation therapy in terms of normal tissue sparing. We can try to implement the technique as well in conventional Linux, although, well, there's some limitations here. In particular, the approach of my team is to use flattening free filter Linux, and we managed to implement the technique with beams of less than 1 or 2 millimeters. And we performed some animal irradiations, demonstrated that rat brains are able to withstand 55 grays in 1 fraction. That is quite enormous dose for 1 fraction. There is also the possibility, as I told you before, to work with charged particles. And in this context, one of the most explored techniques is the so-called proton-Minibeam radiation therapy. What has been observed with this technique is a technique that is able to provide an increase of therapeutic index even for very aggressive tumors such as high-grade gliomas. In this slide, I show an illustration of the results existing. For example, we were able to obtain 70% long-term survivals free of tumor in glioma-bearing animals with 25 grays in 1 fraction, and all of these accompanied with a net reduction of neurotoxicity. In the standard proton therapy group, we observed severe damage in the brain and the skin, while this was not the case in the case of proton-Minibeam radiation therapy. No skin or brain damage, and also we performed some behavioral tests showing that there is no impact on memory or anxiety and some others. We have recently extended this evaluation in the context of brain radiations. As you know, brain radiation is now a hot topic in radiation therapy. And we thought that since mini-beams are able to provide this high normal tissue spraying, maybe they can do the same in brain radiations. So we irradiate the whole brain of rats, except in the olfactory bulb, with conventional radiotherapy first, and then 2 months after with either conventional or proton-Minibeam at the same level of dose. And we have performed a behavioral test 3 to 6 months after the first irradiation. And what we have seen is that when the irradiation is performed with conventional radiotherapy, we have extensive brain damage, which is not the case when the irradiation is performed with proton-Minibeams. We have completed this study with behavioral tests and showed that there is an advantage in terms of memory, preservation, anxiety, and so on in the context of brain radiation with proton-Minibeams. We have also evaluated the context of lung thoracic irradiations because somehow this one was one of the most challenging indications. There was this question mark of whether the breathing motion was going to alter very much the mini-beam patterns and produce or decrease the spraying capacity of mini-beams. So we compared the response of whole thorax irradiation with conventional proton therapy and proton mini-beams at the same in dose, 17 grays. And as you could see here in this figure, the animals receiving conventional proton therapy exhibit important lung fibrosis, which is not the case of the proton mini-beam ones. And also proton mini-beam was very advantageous in some other endpoints, like for example, thickness of alveolar septa, clap cells, and some others, indicating that this technique will handle well in these challenging conditions. But mini-beam could go even farther, and we believe that there is some advantages in combining the technique with heavy ions, such as carbon ions or neon ions. Why? Because those ions have a less multiple color scattering, so if we can obtain sharper profiles, this could be beneficial for normal tissues. But as well, carbon ions and some other heavy particles have demonstrated to be more efficient in activating the immune system. So we can expect maybe some synergistic effects with the effects of the mini-beams. So thanks to the support of HITRIplus, we went to GSI to work with our colleagues over there of the biophysics department. And we performed an experiment in which we irradiated LMUs, osteosarcoma models, subcutaneous models, either with conventional standard carbon irradiation or with carbon mini-beams. In the case of the mini-beam irradiation, 80% of the volume received less than 2 grays, so very, very low valley doses. Nevertheless, if you see the figure in the blue core, we obtain a significant decrease or significant delay in tumor growth, despite the fact that most of the tumor volume received less than 2 grays, so indicating the activation of distinct biological mechanisms that we'll need to keep exploring further. What I would like to highlight is that the valley dose needed to obtain this tumor growth delay was somehow less in carbon than in protons or in X-rays, indicating that there's a difference between these different types of particles. Also, some years ago, we were reflecting on the fact that very heavy ions were used in the past and demonstrated to be very efficient for the treatment of hypoxic tumors. However, those ions such neon, silicon, argon were abandoned due to important side effects in normal tissues. So we hypothesized that if we combine the advantages of those ions for hypoxic tumor killing with the sparing capacity of mini-beams, we could be able maybe in the future to use again those ions in a safe way. So we were lucky to try to demonstrate our hypothesis. We were lucky to obtain some bin time at IMAC in Japan, and we performed an experiment in which we compared the response of mice in which we irradiated the legs, either with conventional neon irradiation or with neon mini beams at the same level of dose, physical dose, 20 grays. So the animals that received neon conventional radiation, we needed to sacrifice them after 2 weeks because they reached the endpoints. Well, in the Minibeam case, only a mild dermatitis was observed. And these results were confirmed by histology. The histopathological evaluation revealed important damage in the broad beam irradiation and minimal damage in the Minibeam. So those were first results suggesting that Minibeam could lead to a potential renewed use of very heavy ions for therapy. This first experiment was possible thanks to the collaboration of our Japanese colleagues, but also to the funding, to the support of the PTCOG grants that we got in 2019. And then more recently, well, we needed to stop our travel to Japan due to COVID. We were able to resume our experiments recently, and we managed to perform a series of campaigns in which we irradiate this time tumor-bearing animals. In particular, in this latest experiment, we irradiate some mice who were bearing very advanced tumors, very large, and the animals that receive, again, broad beam irradiation, we needed to sacrifice them because they reached the endpoints. But the animals receiving neon mini beam, we observe a significant tumor growth delay, despite the fact that we only have one grace in the valleys, and the valleys were occupying most of the tumor volume in this occasion. So those results indicate or suggest that neon mini beam could be a good alternative for very aggressive tumors. And we hope that we can continue with our experiments in Japan in more sophisticated models in the future. So it is clear that from what we have seen in different experiments from different teams, etc., is that Minibeam for sure activates a distinct radiobiology. There's several indications in the literature in general in SFRT that we have a different radiobiology, including different vascular effects, immune modulation, bystander-like effects, and some others. I don't have the time to go today into detail in all of that, so I will concentrate only in a couple of effects. In particular, I will spend 30 seconds talking about potential different vascular effects in SFRT. And for me, there is an issue in which we need more systematic evaluations, more work. Certainly, there is something different here. In the context of Gris and Lattice, they seem to go in the same way or act similarly to stereotactic radiosurgery. In particular, for example, most of the responders have an increased effectorial sphincter melanas and ceramic levels that are related to endothelial apoptosis, like it was observed in stereotactic radiosurgery. However, in the context of microbeam and minibeam, what it was observed in some works, it was an altered blood vessel integrity in the tumor. But then in some other experiments, some other groups reported a kind of tumor vascular renormalization. In particular, the group of North Carolina reported kind of vascular normalization 58 hours after mini-beam irradiations in some tumor models. And this indicates kind of tumor vascular reparation, which might not be contradictory with tumor control. Indeed, we see tumor control. But my favorite, what I think is one of the main aspects in mini-beam anti-tumor response, that is immune infiltration. You need a functional tumor vasculature to be able to let the immune cells to infiltrate. So in that sense, in my group, we have been very much involved in the last years in trying to understand this immune response. And for example, we have compared the response of anemic rats bearing gliomas and immunocompetent rats. We saw that the neutral rats did not respond to the treatment while the immunocompetent rats did, and this was pointing at the T cells as key and the PMBRT mechanism. We have also performed some rechallenging experiments, seeing that Minibeam elicits a long-term anti-tumor immunity, a kind of vaccine effect. And in some single-cell transcriptomic studies, we have seen that Minibeam leads to a lower T-cell exhaustion and a higher expression of esteem pathways actors, indicating a different immunomodulation here that we are now getting deeper and deeper in this comprehension. Where I think that we have more question marks is in the normal tissue sparing. Why we spare normal tissues with Minibeams and some other SFRT techniques? There has been too many hypotheses in the literature. The first one is a prone vascular repair, only observed in microbeam radiation therapy, but not in the other techniques, really. We need more systematic evaluation. And also this famous hypothesis of Dilmanian, where he proposed that the stem cells in the valleys proliferate and migrate to recover the tissue in the peaks. But so far, there has been a couple of relevant experiments demonstrating it, and for example, in tissues like the skin. However, for me, it does not clearly explain what happens in the brain, what the neurons have not the tendency of migrate. So it's quite difficult to explain what we see in the brain. So what we are doing is now systematic omic experiments to try to see if we obtain some hints of potential mechanisms to explain both tumor control and normal tissues. And in particular, we are using a lot of spatial transcriptomic now. I think it's well suited with the spatial nature of Minibeams. And what we are seeing very preliminary is that Minibeam activates, in terms of normal brain, modulates a lot of neurotransmitters finally, so suggesting a kind of positive bystander effect. So now is, as I told you before, I think it's a very exciting moment because since some years ago, the data acquired, and I have only presented a little bit, but the data acquired was convincing more and more the community to go towards clinical trials. And in this path, what the community has been doing in the last years was to try to understand the influence of the different parameters. As you know, in Minibeam and SFRT in general, we don't have only one parameter. We have peak valleys, peak dose, valley dose, center to center distance, peak to valley dose ratio, beam width. All of these influence the biological response. And it's very important, or it was important to try to have a minimum comprehension of the importance of those parameters in terms of biological response. So what we did with a group of colleagues was to try to understand from preclinical experiments, try to extract what was the most influential parameters. So what we saw is that in terms of increased lifespan, in tumor-bearing animals was the valley dose, the parameter that was mostly correlated. Then to try to validate it, what we performed experiment with one of my students with same valley dose, different dose heterogeneity. What we saw is that at the same valley dose, again, we obtained the same increased lifespan, but the number of long-term survivors free of tumors were higher in the case where we have higher heterogeneity. And this was correlated to a reduction of Tregs, a reduction somehow of immunosuppression. So for me, this was a message that, well, dose heterogeneity is somehow important in the tumor. And most recently, we have been working on trying to understand what is the influence of the parameters of normal tissue response. And somehow in the community, in the discussions, there was a general assumption that valley dose was the most important parameter in normal tissue response in Minibeams. And again, by doing retrospective evaluations, what we saw is that when the beams are very small, very narrow, such as microbeam radiation therapy, then valley dose is the most dominant parameter. But when we increase the beam width up to the level of Minibeams, then peak doses start not to be negligible. And this is something that we need to take into consideration for future patients, future treatments of patients. Another factor, another parameter that has not been really that much explored in SFRT in general is fractionation. So what we did is to evaluate crossfire geometry, whether a couple of fractions did better than one fraction. And this was actually the case. When we fractionate when we deliver into fraction space by 48 hours, we obtain 80% long-term survival free of tumor. This was our best result ever in terms of survival in glioma-bearing animals. So all of these for the parameters. And then I think one of the highlights of the last years in terms of Minibeams, apart from the, of course, patient treatment, is this nice veterinary trial performed in Canada, where they treated 8 dogs bearing gliomas with Minibeam, 8 dogs in conventional, and they observed that 70% of the tumor of the animals receiving Minibeam radiation therapy presented complete pathological remission without any toxicity. So all these results put together, I think they are good arguments to move towards patients, to move towards clinical trials. And in that sense, I think Minibeam can get a lot of hope for very difficult cases today, such as gliomas and some other kind of tumors that we cannot effectively treat. I think SFAT in general, but Minibeam in particular, is a robust technique. The toxicity does not depend on beam parameters, oxygen levels, etc. We always see what we expect. The maximum peak doses are approximately known, and many patients have been treated already with lethal lattice with reasonable toxicities. It promises for rate radiations and can be used for effective combinations with immunotherapy drugs. So I think it's the moment arrived for treat patients, and Michael Grams will now discuss about it. I think it's the time to abandon the orthodoxy and embrace new philosophies, new ways of doing treatments that might look heterodox by being more efficient. And last but not least, I would like to acknowledge the hard work of the members of my team, Project and Radiotherapy team, and of course, all of you for your attention. Thank you very much.
Thank you, Yolanda, for excellent talk and guiding us over the last 10 years. I've been watching this field growing and bringing us to the point now where we welcome our second part of the double act, Dr. Michael Grams, who's going to discuss, as Yolanda has alluded to, the very first clinical implementation of Minibeam radiation therapy. Michael is a medical physicist and associate professor researcher at the Mayo Clinic in Rochester, Minnesota. And of course, nobody should be surprised that his clinical and research focus is on Minibeams. So Michael, please do tell us tell us about the implementation and why and how and where are we going? So the floor is yours, Michael.
Thank you very much. Thank you to the organizers for inviting me, and also to everybody who signed up and are watching online today. So my name is Mike. I'm a medical physicist at Mayo Clinic. I'm going to tell you a little bit about why we wanted to implement Minibeam clinically and how we did it. So there'll be a little bit of overlap with some of Yolanda's slides, but I'll try my best to give some additional perspective. So everybody here is familiar with the idea of conventional radiation. You're covering the whole target. Yolanda talked about large-scale SFRT techniques where the irradiated regions are maybe a centimeter or so wide, like grid and lattice. And Mayo and many other centers, probably some of yours are doing this right now. But the point that I want to make is that with the high energies, you are limited by how small and how close you can get those irradiated regions and still maintain a high degree of heterogeneity. And this could be a significant limitation because for many, many decades now, people have shown repeatedly in the lab that there's benefits to making things very, very narrow and very, very, very close together. But because of a lot of technological challenges, these microbeams where the irradiated regions are less than fractions of a millimeter wide haven't translated to patients. So the focus on our program and our research and our clinical implementation is on Minibeams, where we take the same idea, but we just make things a little bit larger. So the irradiated regions are still sub-millimeter, but they're a little bit bigger than microbeam. And because of this, we can translate these with existing KV sources. And these still have very, very high clinical potential in our opinion. So kind of hitting on this idea of why, again, why would you ever want to do this? Well, Yolanda did a great job going over the preclinical work. And this has been around for more than 3 decades, maybe 4 or 5 decades, right, by now, where they've shown very distinct biologic benefits to microbeams in both tumor and normal tissue, or this idea of of shrinking the irradiated regions and getting them closer and closer together. So the preclinical data is pretty much off the charts here. You can deliver hundreds, sometimes thousands of gray. You see little to no normal tissue toxicity in the lab. There's potential bystander effects, vascular effects. You can modulate the immune system in the lab. And all of this for us at Mayo Clinic was more than enough data to justify the clinical translation. So we're building off of the work of others that has been done for decades now, and it was convincing enough to us that we said, okay, it's time to translate this. So Yolanda alluded to this a little bit too, but what's the catch? Microbeam, the data is very, very impressive, but as you can imagine, when you get things very small and very, very close together, any physiologic motion is going to mess things up. You have the potential for the slightest amount of motion to blur the peaks and the valleys together. So historically, the synchrotrons had always gotten around that because they have the ability to deliver thousands or tens of thousands of gray per second. So I've got a couple of examples here, the ESRF on the left, the Australian synchrotron on the right. But these, as you can tell from the pictures, they're very big, they're very expensive. They don't necessarily have a large-scale radiation oncology infrastructure that's going to allow them to treat a large volume of patients. And someday, I do believe that they will translate to patients, but up to this point, the technological challenges have hindered translation. So our hypothesis, and this is nothing new, this was hypothesized by, as Yolanda said, Dilmani a long time ago, by increasing the size and the spacing of these beams to still sub-millimeter dimensions, but maybe 0.5 to 1 millimeter. It's a matter of semantics, what you consider a mini beam versus a micro beam. But the point is you can use these lower dose rates, clinically available dose rates, and still overcome a lot of the technical challenges of microbeams. And furthermore, the other hypothesis we had is these clinical mini beams are still going to have a lot of the same advantages of microbeams. Okay, so you see the picture at the bottom here, kind of just in a cartoon way showing the differences in scale here. So again, Yolanda did a great job describing this, but the concept is you just take a uniform source of KV X-rays, you spatially separate that with some sort of a collimator. We use a tungsten collimator. You can see film here in the green. You see the nice delineation of high dose peaks and low dose valley regions there. And for us, our mini beams are 0.5 millimeter wide and 1.1 millimeter center to center. So to translate this, if anybody knows me, I'm very much a brute force physicist. I always think the simplest solution is the best, and I'm very impatient. So that means that I need things that are clinically available right now. So we have a clinically available orthovoltage X-Strahl unit in our clinic right now. And so we decided to use that and fabricate some tungsten collimators to create mini beams. So it's in principle very straightforward. We did publish this recently. There's a reference there, but the picture on the bottom shows the basic idea here and the simplicity. So on the left, you see a tungsten mini beam collimator. Next to that, you see a commissioning measurement, and then next to that, a film, and then a corresponding mini beam profile in the lower right-hand corner here, again, showing that clear delineation of peaks and valleys. So we did as much as we could, an exhaustive characterization of the dosimetry involved here. And so I'll show you some of the data, but the point I want to make here on the left is you can imagine for different field sizes, you get more and more peaks and more valleys. So we've focused on analyzing the 10 central peaks and the 10 adjacent valleys for our dosimetric analysis here. So we're concentrating on the highest doses that are towards the center of the field here. And here's some data that we've taken here for 180 kVp. So our X-Strahl unit can go from 60 all the way up to 250 kV, and we're going to commission all of those energies. But the general trend is always the same here and is illustrated in these two plots. So what you're seeing on the left is peak PDDs and also lower than that, the valley PDDs in the dashed line at the bottom. And these are for different field sizes to accommodate different tumor sizes. So you can see we've normalized to the surface here. And the general trend is larger field size. Everything in Minibeam is dominated by scatter. So larger field sizes result in larger PDDs at depth and also larger valley doses at depth here. And then the corresponding peak to valley ratios on the right-hand side here have the behavior you'd expect, high at the surface and then diminishing due to scatter within the solid water that we use to commission it. So the big thing that we had to overcome here is that we can't get around the fact that we do have relatively low dose rates. And because of that, patient motion can definitely be an issue. So the solution we came up with here was that we thought if we can attach the collimator directly to the patient, if they're essentially wearing the collimator, that's going to drastically reduce the effects of patient motion during these treatments, which can be 10, 15 minutes long so far. So what I tell our physicians and our therapists who are help treating these, that the idea of putting this on the patient is that if the patient moves, the collimator is going to move with them, and we should be able to maintain the integrity of these peak regions and the valley regions. So this is how we do it. I'll walk you through the topmost picture here. So what you're seeing is we use our existing contouring infrastructure. So this is an Eclipse contouring workspace, and we just create a square structure that corresponds to the size of the tungsten Minibeam collimator, and we place that in a location relative to the tumor and the patient's surface. The tumor here is in green, and then the orange square represents the collimator. So we place that in a orientation relative to the patient that corresponds to kind of our beam angle where we're going to treat this patient. So once we determine the location of that tungsten collimator relative to the patient, we have some scripting and 3D printing technology where we have a template that the tungsten collimator is going to slide into. So that's going to be a 3D printed collimator holder, and you see that in the second image in the middle here. And that 3D printed collimator holder, using the CT scan and the body contour from the patient, we Boolean subtract their skin. And in that way, that 3D printed collimator holder can conform exactly to their patient anatomy, and it fits on them like a puzzle piece. So in the lower left-hand corner here, you can see the collimator. Hopefully in the lower left, you can appreciate there's a slot that the tungsten's going to slide into. And the finished product that we actually used for the patient treatment is in the lower right-hand side here. So you can see that big 12 centimeter by 12 centimeter, in this case, collimator slid into the 3D printed plastic. And I'll give you a fair warning, I'm going to show some pretty dramatic patient photos here, so just beware. Here is the picture from the images on the left. This is the actual patient. He had a very large, painful, bleeding, weeping tumor that was growing out of his ear. It had been surgically resected before, but had grown back. So again, he had a general distrust of the medical field in general. So he had limited options, but eventually was convinced that we could treat with mini beams here. And so you see the picture on the right shows that 3D printed collimator holder. It's secured to him with a strap, and we use some double-sided tape underneath it. And that sticks the collimator holder very rigidly to the person. So it actually works quite well in holding it and making a nice stable setup. And then you see the orthovoltage unit and the cone coming down on top of that tungsten collimator for the actual treatment. And this can be done for a variety of disease sites. So this picture is just showing that we have literally done this from head to toe. So we've treated the top of the head, and we've treated all the way down to these toe, actually, and the top of this patient's foot. And so we can make these 3D printed collimator holders to fit basically any part of the anatomy. This was another challenging case that we've treated. This is probably one of the more challenging ones. This patient had a very large tumor in the axilla here, very painful. He couldn't put his arm down, and he wasn't comfortable laying flat. Those things make conventional treatment very, very difficult. And so we were able to treat him with mini beams, making a collimator holder that, again, adhered to the side of his body. And he was actually most comfortable with his arm up, as you see in the images here. And that actually worked out well because he could rest his arm on top of the treatment unit, as you see on the right here, and sitting straight up in a chair with his arm out to the side here, he was actually quite comfortable. They're not all that difficult. So this is an example of a melanoma on a patient's back. This one is probably the easiest setup. This patient was relatively healthy, could lay prone, no problem, relatively small target here. And what I want to show, illustrate here on the left is that for every single patient, we put an in vivo film, a radiochromic film, directly on the tumor. It's not attached to the collimator. It's not attached to the collimator holder. It's taped directly on the tumor, as you see on the left. The middle pane shows a zoomed in region showing the collimator and the collimator holder a little bit closer, and then the treatment apparatus on the right and the actual way that we delivered the treatment. This particular patient, kind of highlighting the normal tissue sparing capacity. So he got 90 gray peak dose to the skin in 3 fractions and basically no acute toxicity, a little bit of redness, so far no skin irritation or anything like that thus far. And believe it or not, this process worked quite well. You can see here, these are actual in vivo film results from patients that we've treated with this technique. So on the left, you see the black and the green. The black is the region where the mini beams go through. The light green is where they are blocked from the collimator. So you can see this clear delineation that corresponds to the slits and the peak and valleys. Middle is just a color wash showing the dose, and then a dose profile is shown on the far right here, where you can, despite the fact that we're treating these patients for 10, 12, 15 minutes with a relatively low dose rate, with this approach, you can definitely still maintain this clear delineation of peaks and valleys throughout the treatment. And so back to the why, and Yolanda did a great job of getting into this a little bit too, but why would you want to do this? Well, in the early stages, as we're ramping this up, you're going to get a lot of palliative patients. And so we feel that Minibeam can provide an option when there aren't really any others. For example, we treat a lot of patients who have had prior courses of radiation. So we're in a reirradiation setting where we can really take advantage of normal tissue sparing. Physicians are often thinking, if the patient has failed multiple courses of conventional radiation, why would I repeat that again? Why would I not try something new? Our physicians are getting braver and braver. I gave an example where we gave 90 gray in 3 fractions. We have gotten over 100 in 3 fractions already, so we can safely, so far, dose escalate for radioresistant disease. And a lot of these patients have failed on systemic therapy, or the systemic therapy isn't working right off the bat. So kind of highlights this hypothesis or this potential that there could be synergy between the Minibeam and systemic therapy as well. So this is that ear case. So this particular patient got 2 fractions, 18 gray. This is skin surface dose here. So 18 gray to the skin, 1.8 gray valley over 2 fractions. So a couple points here. One is these aren't dramatically high doses, right? And then also a common question is, how do you line up the slits between fractions? The answer is we don't. So we rotate the collimator in between fractions so that you have kind of a crossfire approach here. And you can see the response here over time here, day 16 and day 34. These patients oftentimes come back. We treated 27 now, I think. Oftentimes these patients will come back the next day and they say, it doesn't hurt as much anymore, or it's not bleeding or weeping as much anymore. So we're seeing a very prompt response and palliation for these patients, which is very rewarding. You can hopefully notice in the middle picture here, and especially on the far right, his ear canal opened up. He got his hearing back as well in a relatively short time. And he went on to surgery after only 2 fractions of Minibeam, and then was deemed to have a complete pathologic response. Was on prior immunotherapy, no effect. And then, perhaps coincidentally, the Minibeam, once that was administered, he had a nice response. This is the armpit that I showed earlier, the axilla, same story. A little bit higher dose in the peak regions, 19, 2.3 gray valley, 2 fractions, day 23, you see a very nice response here. Very prompt pain relief, regained full range of motion very quickly. This was another big case for us, I guess, in the sense that this was a young patient, married, has kids in high school, had head and neck cancer, and very quickly after her standard course of proton radiation therapy, within a few months, she recurred, and it came back very aggressive. So You can see here she had a tracheostomy. The physician was worried that the tumor was growing so fast it was going to suffocate her and close that off, despite the fact that she was on the what the physician characterizes as the most toxic and aggressive combination of chemotherapy that he'd ever seen in his career. So he wanted to do something quickly, so he decided on Minibeam. He got a little bit more aggressive here. You can see 26 gray peak, 3 gray valley times 2. Again, not astronomically high doses, not hundreds of gray here. And you can see the time lapse of her response here on the left. So 3.5 weeks later, the tracheostomy is opening up. You can see some tumor response, definitely in the CT at 10 weeks. And she's, I think, 6 months out now, doing well, no pain, no toxicity, and no evidence of disease at this point. So there is definitely still room for improvement. We could benefit from higher dose rates. If somebody gave me a higher dose rate source, I would definitely take it. 10, 12, 15 minutes is still a long time. This is going to allow us to escalate doses higher over time as well if we could do it a little bit more quickly. And a big point here, we absolutely have to work through the stages of clinical trials. So phase 1, phase 2, hopefully phase 3. Otherwise, we're not going to know whether this is really helping patients, right? We have anecdotal cases, we have an early experience right now, and I think we definitely can help patients, but you don't know until you go through clinical trials. And we're going to need consistency in how we run those trials in terms of clinical parameters. How are we going to evaluate these very complex Minibeam dose distributions? And so to that end, Monte Carlo is going to play a big role here. So we need to develop Monte Carlo dose calculations in order to correlate these delivered Minibeam doses with patient outcomes. And I want to highlight a couple of my collaborators at the University of Wollongong in Australia who are helping us with this, using decades of experience with Monte Carlo in synchrotron microbeams, and they're helping us with some Minibeam Monte Carlo as well. And so these are just a few pictures to show that complex dose distribution. So on the left is a film measurement where we've rotated the collimator by 90 degrees. But we're also going to do 3 fraction treatments, and we have done 3 fraction treatments. So hopefully you can appreciate the 45-degree rotation here. And just looking at the heterogeneity in that film measurement, you can imagine the complexity and what are the biologic impacts associated with that complexity. We have to know what we're delivering in order to correlate it with outcomes. So for an example, such as this one that I'm showing here, this is a nice example because we didn't even cover the entire tumor, because we didn't have a cone that was big enough to cover his entire tumor. You see a rough Monte Carlo in the lower right here, and you can tell you're not treating very deeply here as well. And these are some early results here. I'll just speed up, but the takeaway here is for 180 kV energy, our film and our GEONT4 simulations agree very, very well in the peak. But as you might expect, or if you're familiar with the literature, the valley doses are very, very difficult here. So GEONT4, just like microbeam, tends to underestimate the measured doses in the valley here. So we still have some work to do there. I'm going to finish here. I just want to say thank you to, this is a very big effort at Mayo Clinic. Jen Fazari, Waping Zhao are research fellows that do a ton of preclinical work for us driving this forward. Several of my physics colleagues are up there. My international colleagues, Valentin Jonoff from Bern, Yolanda, of course, who's on the call, Michael Lurch and Susanna from Australia. And then I also want to highlight in the lower left here my therapist colleagues, because you can imagine they play a huge role in actually figuring out how to treat these patients as well. So I'll stop there and hopefully we have some time for questions. Thank you all.
Thank you, Michael. Excellent talk. Also, thank you, Yolanda. So before we have the questions, we will do the usual Zoom photo. If you don't mind, could you turn your cameras on? And for your questions, you can either put them on the chat or you can put your hand up, so as you like. So Angelica, ready for the photo?
Yes, I'm ready. What
Great.
about your smiles? Okay,
Vic,
I will
put your camera on, Vic.
Yes, please. Okay, just another second. Sorry. And I'm taking the second one. And okay, I got it. So now you can relax.
Thanks a lot, Vic. You are first on, so please go ahead.
Okay, thank you. It was fascinating talks, but I couldn't help thinking that some of the stuff that Yolanda was talking about is very reminiscent of talks I've heard about flash therapy. So my question is, why is there so much similarity, or at least apparent similarity, between what is being proposed in terms of the new radiation biology for flash and for Minibeam therapy? Do you have any comments on that? And are they complementary?
I don't think there is similarities or that much similarities because, for example, flash, I think SFAT in general works a lot through the immune system. And in flash therapy, where it has been published both from my team and Marie Catherine both now team, is that the immune system does not play that important role in the case of flash. In terms of bystander effects, I don't think this has been observed in flash. I would think that maybe there is some similarities, maybe some vascular effects, but needs to be explored. So for me, the techniques are not that similar. Maybe they are complementary in some senses, but not. I think flash works mainly through radiochemistry effects, and these other techniques is more tisular effects, if you want. I don't know if this explains your question.
Okay, thanks, Yolanda. Mike, do you have a comment?
Everybody's chasing the same thing, right? They want less normal toxicity, higher doses, immune stimulation. I think it just remains to be seen. I think they're both after the same thing, but what I like about the Minibeam is the simplicity of it, right? We have existing equipment that anybody has access to. Also, I think this highlights the importance that we need to look at late effects too, right? So there's been a really nice study in animals with flash that showed some late toxicities. Are we gonna be dealing with that in patients? So I think it remains to be seen, but they are similar to each other.
Mm-hmm. Thanks, Stuart.
Hi, yeah, thanks for those two great talks there. So this is, I guess, a question for both speakers, but in picking your valley doses, are you specifically aiming for doses which are low enough so that you think the T cells that are there will survive, the immune cells that are already in that tumor region? Is that the main consideration in picking the valley dose?
Do you want to go, Yolanda? Yeah.
In the experiments we use, especially in our experiments in X-rays and protons, we use high valley doses. What I have read in the literature is that the T cells that are in the tumor are more radioresistant than the circulating T cells. So it's not that we perform our experiments seeking valley doses that are low enough to keep the T cells. I think the treatment in Mayo Clinic is using a different philosophy, as far as I understood, but not in our case, at least.
Okay, thank you.
Yeah, I would just add a couple things. One, in the lab, we've gone to valley doses as high as 8 gray in mice and peak doses from the 50s up to 100s, and still see evidence of an immune response. In patients, you're limited by it's dictated by the field size. So larger field sizes have higher valley doses. So you kind of have to take what you can get. We've got a phase 1 study planned right now, hopefully going to enroll early next year, where we are going to systematically elevate the valley dose. So we are prescribing to the valley dose, not the peak, for better or for worse. But we're going to systematically evaluate that in a phase 1 setting to kind of get an idea of what's the maximum tolerated dose. And then secondary correlatives will be the immune response. So,
okay, thank you. Fantastic.
So Radhe, you are next.
Yeah. So when you compare outcomes with conventional radiotherapy, do you compare using the peak dose or average dose or integral dose between the two, or do you
well, in our experiments, we compare in terms of mean dose or integral dose, most of the time mean dose. In proton therapy is more or less the same in the small volumes that are we targeting in small animals. We don't compare in peak dose or valley dose because somehow it's a little bit unfair, or it's my view, because if you compare in valley dose, in Minibeams, you would have been depositing much higher integral dose than in conventional, for example. So I don't think there is no one that can say that we have a good method of comparison between conventional and Minibeam. What I think is fair to say is that the mean dose in our experiments, at least in our model of glioma, rat glioma, and so on, the mean dose is giving most of the time the same average mean survival, so the same increased lifespan. So we are comparing more or less at the same efficacy level. So we consider that is somehow fair in that sense.
Yeah, we have a similar approach. We've kind of blanketed or bracketed everything. So when we do conventional comparison to conventional in mice, we will treat them to the same conventional dose as the peak dose. We've treated them to the same mean dose, and then we treated them with the same valley dose just to try to cover everything. But I agree with Yolanda. There's not a great way to compare apples to apples between the two groups. So we try to cover all of our bases.
So is there a need for developing some sort of a metric? And, perhaps, when you compare one Minibeam technique with another Minibeam technique, there also you may face the same thing, right? So is there a need for a metric, novel metric that may be biologically effective dose, perhaps, or something like that?
Yeah, I agree. Perhaps the equivalent uniform dose with all of the assumptions that go along with that would be okay. But yes, something to tie the two together is a big need.
Thank you.
Okay, Julia?
Yes, I had a question for Dr. Prezado. You discussed the use of charged particles, such as heavy ions and protons mainly. I wanted to know what are your thoughts on the use of electrons, or is that something being investigated for mini-beams?
There are some groups investigating the use of electrons and mini beams in Italy, mainly, I think. Electrons are a little bit tricky because you have a lot of lateral scattering, so you have to really play tricks to get your mini beams. Then in the past, we proposed a combination of very high energy electrons and mini beam in a paper we wrote in 2015. Still, I think electrons are, among the charged particles, the most difficult to work with in terms of mini beams.
Okay, thank you.
Mm-hmm. Michael, any thoughts?
Nope, agree. Yolanda's an expert more than me in that area, but I did see a nice paper that came out recently where they're looking at electrons in a mini-beam sense. And the takeaway for me was they found that you get spatial fractionation over about the first 4 millimeters or so. So I think that's going to be the challenge with electrons. Whether or not that matters in all scenarios, we don't know, but yeah, it was interesting.
So Raj.
Yeah, great talks both. If I may, I have one question for each speaker, one biological and one physics. Yolanda, it's intriguing that you'll correlate some of these effects in terms of the effectiveness between valley dose and width to certain endpoints that we recognize well. And you mentioned some of them are well recognized from SRT response. My question is, if you look at things like CGAS sting, ceramide production and stuff, do you know that they actually stay within the same spatial range as your peaks? And to what degree these signals, which are obviously highly injurious and will typically trigger cell death, actually leak out into the valleys?
Yeah, I don't have data to prove that. I was hoping that the spatial transcriptomic data that we are acquiring helped us in that sense, and then try to go for more biological validations. It's very difficult to obtain the data you are requiring or you are mentioned. For the moment, what we are doing is more global experiments, taking the full tumor and so on. So it's difficult to conclude.
Thanks. And for Mike, we talked about the value of high dose rates here to freeze movement effectively and maintain our peak to trough ratios when bringing these things into the clinic. So my question is to you, is it easier to get high dose rate into the clinic, or is it easier to get fast imaging and gate into the clinic? What do you think will be the future?
That's a great question. I think So I should have clarified that when I say high dose rates, I don't think we need flash dose rates. Or I would be happy without flash dose rates. If somebody can give me a factor of 2 or a factor of 10, I would be ecstatic with it. I think that is capable with electron impact sources that are appropriately cooled right now. And if somebody said we could increase your dose rate by 10 or 20, that would be tremendous. Gating, I think, is going to be a lot trickier. I haven't thought a lot about that in terms of the Minibeam, the effects on Minibeam and gating. And to be honest, I would like to avoid that conundrum altogether. So my personal bias, my thought, if you asked me, I think it's fast. It would be easier to get faster dose rates into the clinic rather than come up with a gating strategy. So, but we'll see.
Thank you.
Thank you. Any other questions? If not, I have a question for Yolanda first. You know, you've been working on mini beams, as I know, for a long, long time. Is this how you thought it would be clinically translated when you were imagining this, say, 5 years ago?
Oh, I didn't have an a priori. As you know, we have been trying to do these clinical trials in brain tumors because our experiments were very much focused on brain. So it's not that I was imagining any other alternative that is better or worse or whatever. I think is really very good news for the field that this has been done. The results that Michael Grams presented are amazing. You have seen this head and neck tumor, very aggressive, that disappear after a couple of fractions. So I think this opened even more possibilities than I thought in the beginning. So I'm really, really happy, really excited about the future of the technique, and I think we have very interesting times ahead of us.
Thanks, Yolanda. So Mike, from your perspective, now that we have the translation, which, as Yolanda says, excellent news, really opens a field, there's a lot to do. What do you think needs to be done to push the field even further?
I think we need a couple of things. One, we need a really good mechanistic understanding of what's going on here, and we need clinical trials. And both of those things, if you don't have them, you're not going to get buy-in from other people. You're not going to get buy-in from the community or physicians. And I think we really need to take an unbiased approach here to the science and do these mechanistic studies, do the trials, because I think, you know, it's easy to get excited and people show these anecdotal cases and, you know, they're amazing. And I can say that in our early experience, the response rate to this treatment seems to be higher than what we get with larger scale SFRT techniques. But again, we have to work through clinical trials to make sure that this is helping. So we want to do a phase 1. You have to find the maximum tolerated dose, safety, feasibility, and then you can start working through phase 2 trials and start looking at response and efficacy. But in parallel to that, we have to do the basic science as well and understand the mechanism.
Mm-hmm. No, absolutely agree. The clinical trials are a must. So what is going to be your primary site for a clinical trial, do you think?
As you can tell by the pictures that I showed in the phase 1 setting here, we have to take kind of all comers here. So we have a phase 1 trial design where we have 2 cohorts. We have a cohort with what we call intact skin, and we have a cohort with disrupted skin. So as you can imagine, you know, if you're looking at toxicity and superficial treatments like mini beams, you can imagine intact and disrupted skin are going to have different levels of toxicity. So we've chosen to separate those two. However, these are going to be, there's no specific disease site. It will be soft tissue tumors amenable to mini beam radiotherapy, which means we're not going to treat a prostate or something 15 centimeters deep in the thorax or anything like that. So, yeah.
Okay, thanks. Sam?
Michael, I got a question for you because here you're bringing up a very important point here. So from my understanding is that there have been some, well, my first question is this SFRT technique, whatever it is being delivered, ready to go in the clinic? That's one. And two, I think I've read somewhere that there are some clinics, I believe in the US, who have started actually doing treatment. And please correct me if I'm wrong.
You're correct. One, I think it's ready to be in the clinic, and two, we have done it. We might be the group that you were referring to. I think Mayo Clinic is the only group so far that I'm aware of that has treated patients with Minibeam. So yes, I do think it's ready for the clinic. We're treating patients. We've treated 27, I think, so far, and then now ramping up to a phase 1 trial early next year.
I see. So phase 1 has not started yet.
No, not yet.
Okay. So your recommendation, because here we are faced with, we're also discussing this, and personally I'm pushing for, you need to validate, you need to have a clinical trial, etc., just along the same lines as you said. Do you think that is the way to go?
I do think it's a way to go, and I realize I'm kind of talking about out both sides of my mouth because I'm telling you we've treated 27 patients and we haven't done the trial yet. However, okay. There was a huge advantage to us in treating that small cohort of patients because we refined the technique and we learned a lot about how to do it. And we did not want to have to figure that out on trial. So we wanted to work out a lot of these details, but 100% agree. And we have slowed down tremendously with treating patients because our phase 1 is imminent now. So after that, there's no patients treated off trial at Mayo Clinic.
No, that I agree with you, Michael. I think treating a small cohort of patients initially is primordial because that is the only way to see if it's feasible. It's the only way to work out the workflow. And that's also the only way it's gonna actually guide you to come up with an impactful protocol. So
yeah, I can't agree more. You learn a lot very quickly when you move from a mouse to a human. There's a lot of things that pop up that you don't have to deal with when you're talking about a mouse.
Great, thank you, Michael.
Thank you. So I think that I'm conscious of the time, so I'd really like to thank both Yolanda and Michael for excellent talks and for actually opening the way for a new modality. So thank you so much. And we'll see you next time. Thanks again.
Thank you very much. Thank you.
Thank you. Bye.
Bye.
Thank you all. Thank you very much.
Thanks a lot. Thank you.
Bye.
Bye-bye.